All right, good morning. Good morning, everybody. Thanks for coming. This is a terrible lecture. It's pretty thick. I stole the vast majority of this talk from Chris Visco, who is at Columbia. He actually made it kind of interesting. So we're gonna go ahead and get started. This is the basics of ultrasound. So a lot of this is on the CAQ, or if you're gonna take the RMSK, it'll be on there as well. So a couple of the objectives, we're gonna go over a brief history, we're gonna understand the basics of physics and how it applies to musculoskeletal ultrasound, and then we'll talk about instrument optimization and some common scanning techniques. So briefly, down in the lower right corner, Lazaro he was late 1800s, figured out that bats used some sort of sound waves in order to not run into things at night whenever they flew. So it took about 150 years or so before they started using hydrophones on subs. They didn't really have echolocation until a couple of Harvard students figured it out in 1938. About 10 years later, John Wild used ultrasound to be able to look at the intestine. 2 years later, they founded the AIUM, which is what we still use today. They realized ultrasound was going to be an important technology. And then first report of something that we would use would be articular cartilage was by KT Dusick. So in the 70s, you had the first B-mode scanning, which was described by radiologists. In the 80s, you developed some high frequency transducers. They were unrecognizable because the screen was that little tiny window at the top there. But radiologists and OBs were using it to listen to heartbeats of babies or fetuses. In the 90s into the early aughts, you started to see the decrease in the cost of the machinery. You started to have some early adopters for clinical use. You started to see some education in clinical applications, especially in the emergency department. In the last decade or two now, you're starting to see increased use application across all areas and disciplines. You're starting to see some pioneers do some really interesting things with ultrasound. You're starting to see some textbooks and educational standards. So the machines got a little bit better, the screens got a little bit bigger. That's kind of the late 80s, 90s machine to down to what we're using kind of today. You started to see, again, the curriculum, so this is 2014, that was just more of a guideline, and then they came out in 2022 with the new society guidelines for fellows that we're using here today. So just to give you an idea, there was a study done in one of the Scandinavian countries, and this would have been the early 2010s, where they gave, basically they took 100 cardiac patients, some of which had normal exams, some of which had different pathologies. They pitted first-year medical students against cardiologists, all of which that had 15 years worth of experience. The medical students were given ultrasounds and about a 90-minute crash course on how to evaluate the heart on ultrasound, and the cardiologists were given their stethoscopes. And then they were told to make diagnoses on these 100 people. The cardiologists were something like 57 or 58% correct. The medical students were 97% correct. So as the cost starts to come down, I believe that ultrasound is going to eventually replace the stethoscope. I think you're going to see it more and more. We'll talk a little bit whenever we get into some of this as far as how ultrasound works. So getting into the physics of it a little bit, you have what's called a reverse piezoelectric effect. So you get an electric current that comes down the wire into the piezo crystals that are at the bottom of the Transducer, this is what makes these transducers so expensive. I mean, it just looks like a piece of plastic and some wire, but they're anywhere from $4,000 to $12,000, depending on which ones you get. So the crystals are very thin, and there's a piezoelectric element there. The frequencies are going to be greater than 20 kilohertz, which defines ultrasound, so you can't hear it. It transmits the signal down into the tissue. The piezoelectric effect is what is detected by the signal coming back. So as the waves return to the transducer, you get varying electric potentials assigned to grayscale, and it converts it to an image. So that those waves come back, it gets converted to electricity and turns into the image that you see. So as it comes back, we have the signal to noise ratio or signal attenuation. The higher the SN ratio, the better the picture. The machine can be tweaked, optimized so that structures are contrasting with minimal absorption. A low SN ratio is going to be the worst picture, with the waves being more scattered or absorbed. So there you see the difference between a sine wave. So those are both sine waves, right? And we can't do the first one because there are too many structures, there's too many sound waves that are coming back in different directions. And so what we want is some combination of the two. You can still tell that that's a sine wave, you know what you're looking at, much more recognizable than the bottom one, right? All right, so more physics here. So the transducer is going to have the sound waves going down to the tissue. The only thing that the transducer can see is the sound waves that are coming back, right? So this is the picture that you end up seeing. So what can happen to make the area lighter or darker? Hypoechoic, and we're going to talk about these terms a little bit later on, but we talked about it a little bit yesterday, where something is hypoechoic, hyperechoic, something is in short axis or long axis. Just saying that doesn't mean anything. It has to be in relation to something. So you just don't want to say that's hypoechoic. Well, it's hypoechoic to bone, sure, but is it hypoechoic to something else? So a couple of things that can happen to the sound waves. Absorption, that is what will create heat. So how do sound waves get absorbed? They get turned into heat. That's the utilization that physical therapists use ultrasound for, creating that heat at those deeper tissues. So not as many sound waves come back. You get reflection, where the sound waves hit something and bounce off. And then you get refraction, where the sound waves hit something and then go through, but at a different angle. So this is refraction, right? It's the broken pencil trick that you get kids with until they hit about kindergarten and they realize what's going on. But the physics of what's happening is the speed of the wave through the different material changes how you see. Now, these are obviously light waves, but the same thing happens with sound waves. So it's the same idea, that refraction. So this is refraction. So what's the material that's going through the vessel there? It's blood, right? So it's a liquid, so it's going to refract some of that material. So what you don't want to do is say, oh, there's an area of hyperechogenicity here. It's all the same as the rest of the tendon here, but the only reason this part looks brighter is because the sound waves have been refracted by going through the vessel, and you can see this shadow coming here. So you don't want to say this is a tear here or this is hyperechoic here. It's just the refraction of the sound waves coming through. Reflection, some of the propagating sound waves strike a boundary between two media and return to the transducer. So that's why it looks like the clouds are in the water, right? It gets reflected back. It's a mirror effect. And so this is where you get the cartilage sign. So you're only going to see the cartilage sign or the cartilage interface sign where you are exactly parallel. This is still cartilage going down, but now those sound waves are bouncing out this way and you don't have straight reflection. So that's where you get a cartilage interface sign. And the reason for that, what's cartilage made of? Mostly water, right? It's mostly water. And so that's why you get that reflection there, because there are two different media in that boundary. All right, so what happens to the sound? Hypoechoic is going to be dark. Hyperechoic is going to be bright. So that's passed through, scattered, or absorbed more easily is going to be the dark. And everything goes back to the transducer is going to be bright. So that's hyperechoic. That's going to give us shades of gray. And so you can kind of see here, right? Like The biceps tendon here is hyperechoic compared to the deltoid, but it's hypoechoic compared to the bone. So it's got to be in relation to something. And then you can kind of go backwards from there, right? So hypoechogenicity is relative within the field of view. So scatter, you can get reflection and refraction of the waves away from the transducer, makes it more difficult to see. And I'll show you guys, I have a pretty good video here in a minute. So a couple of different terms here when we're talking about structures. And so you can change the hypo or hyperechogenicity or the echogenicity of the structure by your angle. And some structures are going to be more susceptible to that than others, and we call that anisotropy. Anisoptra is the official term for a dragonfly. And so if you look at the dragonfly's eye under a microscope, this is what it looks like. It's all the same material, but because of the way the light is reflecting, you have areas of hyperechogenicity and hypoechogenicity. So the people that started looking at ultrasounds, a lot of it was done in animal models and things like that. Apparently, they knew what a dragonfly eye looked like under a microscope. Obviously, right? So what is anisotropy? And this is something, this would be a good fellow project to get me a new picture. This is a very old picture. It's kind of difficult to see. So we're looking at the patella tendon in trans. That's the angle that we're looking at it, right? So tendons tend to have a little bit more anisotropy. So if we change the angle, now you can see where the patella tendon is, right? Because it got dark. So the difference between that makes it a little bit easier to see now where it is to that. And that's just changing the angle. Now, obviously, this is a little bit exaggerated, but you can kind of play around with tendons and things. So what you don't want to do is say, oh, look, they have a torn patella tendon when it's just anisotropy. That's not going to inspire confidence in your colleagues that you know what you're doing with an ultrasound. So you always want to look at something in more, basically you want to look at it in two axes, right? You want to look at it short and long. So it's kind of the same thing when you talk about x-rays, one view equals no views, right? You want to have more than one view for an x-ray to confirm what you're looking at. Same thing here. So susceptibility to anisotropy, tendons are very susceptible when you go down into muscles, and it's not very susceptible. And that all has to do with the alignment of the structures within that particular tissue, right? Muscles kind of go all over the place. And so so the sound waves are going to come back, even if it's not a very clear picture. All right, so we're going to talk about optimization here a little bit. How we hold the transducer. We want to hold it by the front. So the front, not by the end, right? Toggle, rotate, wag, heel, toe, and pressure. So you don't walk a dog by the tail because you can't control it. So you walk the dog by the head or the front. And so that's why we hold the transducer the way that we do. So talking a little bit here, rotate is going to be changing it in this axis. Tilt is going to be, and that could be toggle also, is going to be changing it in that axis. And then heel toe is going to be changing it in that axis. So we're going to see if I can do this relatively smoothly and share a different screen. Video goes on. Is it down? No, it's not down. It's not down. Launch meeting one, I gotta change it to. I thought I was gonna be real smooth. I'm not. Let's get rid of this right now. So I gotta change this. Here. All right, now we can share. All right, so this is the video that Ben was talking about yesterday. So this video is from 2007. So we're 17 years old. I still think it's one of the best videos here. I'm going to turn the sound off and I'm just going to talk through it because we're going to go through. So this video was initially for the Department of Anesthesia. And so they were looking at kind of tracking needles, but I think it really does a good job of giving you the basics of ultrasound and kind of what you're looking at. So this is an AIUM video. I've stolen it without express copywritten, so please don't send me to jail. So a couple of things that we're going to look at, and we'll skip some of it with needle approaches, but the probe manipulation and scanning plans. So this is what you're seeing, right? And it's very thin. We talked about yesterday that the sound waves that come out of the transducer are about the size or about the width of a credit card, so very thin. So as you move things around, you can do a number of different things, but that's what you're going to see on the screen. And you're seeing that in short axis, which is why it looks like a circle. So if you spin it in long axis, it's going to look like two lines because you're seeing very little of the whole thing. So we're going to go through probe manipulation here. There's a number of different ways that you can maneuver a transducer. Try to call it a transducer. Patients don't like to hear the word probe. It's a little funny, you guys can laugh. So you can move it in different axes. There's the x-axis that way, and then the x-axis that way. There is the y-axis that's going to go that way, long axis with the transducer, and then toggling or tilting back and forth. And then there is the z-axis, which is pressure and rotation. So those are the three axes and the 6 maneuvers that you can do with an ultrasound. So sliding, you can slide in a couple of different ways. You can go in the z-axis, and it's going to give you put it a little bit more in the center. If you put too much, you will compress it. You can go in the y-axis and look at different structures as you go through. You can scan along the we're going to talk about compression. So compression, you're going to be able to kind of bring things a little bit more to the center of the screen, but it can also compress. You have to worry about that with veins. Veins will compress pretty easily. And so that's what we're going to show here. So you can see the vein, you can see the artery, you should be able to see some of the arterial wall there as well, the musculature. And so you got to be careful if you're trying to get to that nerve to hydrodissect it. Okay, look, I don't have to go through any vessels, the arteries far enough away. But when you kind of lighten up, it's be very easy to go through a vein there. So part of the reason why you want to be able to see it rocking, this can be heel toe, so that you can either look at other structures or you can flatten out the needle to make it a little bit easier to see. Rotation. We're going to spin it long ways. We don't really use that a ton. We use rotation a lot, but the reason that they were showing it in this video was for placing central lines. Tilting, kind of looking in. So what you see there is it gets less bright. It gets hypoechoic, and that's because a lot of the sound waves are bouncing off and not coming back. Nerves tend, so we're going to fast forward through this. Go. So next thing we're going to talk about, and this next part is the part that I think is really important to see, because it shows how difficult it can be to look at the needle and also or any structure really. So you can take needle visibility here, and we talked a little bit about this yesterday. Now they follow their needles in. I don't follow my needle in, but you can see that little pinpoint there. It kind of showed up just at the top of the circle, makes it much easier to see it in plane. So we do some things short axis, but the majority of what we try to do is long axis to the needle. And you want to see that stair step at the end of the needle so that you know that's the tip. If you don't see the stair step, then you're not 100% sure where your needle is. This is the video I wanted you to see. So you can kind of see as you tilt that angle and make it steeper, the sound waves stop being reflected. So you can't see that needle at all right there because of where the sound waves are going. So if you look at it, they're going to spin it here. Not only are the sound waves going away from it, they're also being scattered to the left and to the right. So all those sound waves aren't coming back. And so it makes it really can be difficult to see a needle. This is what a needle tip is going to look like coming through. In short axis, the shaft is going to be a weaker signal. So the reason that the tip is a stronger signal is because you're getting reflection on a couple of different surfaces versus things getting refracted away. Sometimes all you can see is the tissue displacement, and that gives you an idea of where your needle is. And sometimes you'll hear me ask you guys to just inject a little bit so that we can kind of see some of that tissue displacement and where the needle tip actually is. Let's see, I think that's pretty much it with this video. Those were the things that I really wanted you to see. They follow their needles in. We'll do this part here. So in plane needle, and so what you can kind of see, you see that nice stair step at the end, the steep angle, how much more difficult it is to see. So the shallower the angle, the better you'll be able to see the needle. So that's why it's so important to keep that transducer pad parallel to the needle. This, they're just going to show a couple of things, so we'll get out of this. They're going to show, this is a good one to see. So if you're out of plane, if you're not exactly in plane and the needle kind of comes between, it's that short, long axis. So it ends up looking like that. Joints, not a huge deal, but if you're doing fine needle work and you're off by a couple of millimeters, you could be going through the nerve when you're trying to hydrodissect it. So you really have to see that stair step appearance. So that's the video. I'll make sure you guys have all of this. Go back to sharing this. That transition was much smoother. So two-step process to set up. So now we're going to talk about the setup of the transducer and kind of how we want to do it. It's in theory pretty easy to do. Then you get into some of these rooms that are not set up to be ultrasound rooms, and then you're kind of going, you're fighting with yourself a little bit. So ergonomic setup. First, you want to optimize the risk of injury. You want to optimize the position to decrease the risk of injury to the patient. All right, so that's the first thing. Second thing is you don't want to injure yourself. So if you look at this picture, you've got, I have no idea what she's actually scanning, but I would hope so, but she's got a gown on, so we don't really know. If she is imaging something of the lower extremity, why are you having her stand on a stool? You know, it seems like a recipe for disaster here. And then if you look at her, if she's scanning like that all day, her neck's going to be killing her, her shoulder's going to be killing her. It's not fantastic. So the environment should be adjustable to the patient, right? Not a good look there. A couple of tips here, bring it close. If you can get it to within 2 feet, that's great. 2 feet's not that far. I think, somewhere between 4 and 6 feet is fine, because what you want to be able to see is your hands, the patient, all the things that Dr. Boswell talked about yesterday in one line of sight without having to crane your neck or anything like that. You want your screen to be adjustable so that you can move it up and down. And we see it, all these rooms don't get completely dark and you've got to adjust for glare a little bit. Dim the lighting. I always try to dim the lighting. Sometimes that works better than others. You still have to be able to see. And then routine use of gloves. If I'm scanning and not doing a procedure, I don't use gloves. I think it's easier to feel the patient because, like we talked about, you should have your ring and pinky finger on the patient to act almost like a strut or a spring to be able to decrease the pressure as much as possible. And then the other 3 fingers are for the transducer. Cord management, don't roll over the cord. Like I said, these transducers can be anywhere from $5,000 to $12,000. And if you ruin it because you just keep running over the cord, it makes it difficult to justify that to the people that pay for it. So now we're going to talk about picking the transducer. So how do you pick the transducer? You've got 2 different types of transducers, right? So picture on the left is getting into the club. You can assume that there's music there. So if you're standing outside, all the doors are closed, windows are closed. What do you hear? Other than people talking, what do you hear from the music coming from inside?
The bass.
The bass. Why?
The frequency.
Right, it's a lower frequency, it's a longer wave, it can travel through concrete, glass, wood, drywall, whatever, right, exactly. But you can't understand the song, right? Because all you can hear is the bass, those low frequency. What are you not getting? The higher frequency. Once you get inside the club, what do you hear? The actual song, you can understand it because you're getting those higher frequencies, so it is a clearer sound, right? So that's the difference between curvilinear and linear hockey sticks. So the lower frequency versus the higher frequency, right? So higher frequency is going to be better resolution, but it won't penetrate as deep. So there's more superficial structures. Lower frequency, it's not going to be as clear, but you're going to be able to see the deeper structures. So your curvilinear, that low 1 to 5 megahertz versus your linear, which is 5 to 18. Usually your hockey stick is 12 to 18, it's usually higher. And so that's how you make the determination. You want to use the highest frequency you can to look at structures. Right, so then you get 2 different columns of sound waves. Linear is going to be just that, linear, and curved, you're going to get a fan of sound waves. All right, so you can adjust a number of things here. Depth, frequency, focus are the 3 big ones. Those are the ones that we're going to use most frequently. You can adjust the dynamic range, the gain, time gain, compensation, and more. There's a ton of things that you can do for the purposes of what we do. Depth, frequency, and focus are the biggest ones. Each ultrasound machine is going to be a little bit different, so you want to become familiar with your ultrasound. So for this one, the depth is there. This is an older GE, similar to the ones that Ben, myself, I think Dan and Josh all use in different locations. Frequency, focus, and then gain. So depth, I have no idea what kind of machine this is. Frequency, focus is up there, and then gain is down there. This is another one, I don't know which one it is, but depth, frequency, focus. So you can see focus is north and south, frequency is sound waves, and then the gain is down below. This is a sonosite, an older sonosite, and really all you could adjust with the sonosite was the gain and the depth. You really couldn't do anything with frequency and focus. So now we're going to start talking about just right, not too deep, not too shallow, so like Goldilocks and the 3 bears. You want to make the center of the screen work for you. So it's going to be transducer dependent, software adjustable, want better resolution, raise the frequency, want more penetration, lower the frequency, right? Again, inside the club versus outside the club.
Are they just set right now on like the highest frequency available? Like, do you guys actually change the frequency?
Sometimes I do. I change more the focus, probably the focus and gain more than anything. I probably don't do as much with the frequency. So again, sound waves move like this, right? They go up and down. So when you have a bunch of sound waves moving together, they can be far apart or they can come near to each other. And so they kind of go like this, right? The most sound waves are going to be in the thinnest part or the valley there, not the peak. They're going to be furthest away at the peak. So you're going to get the most focused sound waves at that valley. So the narrowest region has the best resolution. So that's your focus. So that you can move around and that will bring things into focus. So these arrows out here are the focus. If you're looking at something down here, you can see it's not that bright. When you change the focus to look at that structure down there, it makes it a little bit brighter, right? Old machine, not great, but the difference between that and that can be enough to help you make a diagnosis or see what you need to see. So you want to avoid this. Why? Because the whole bottom of the screen is black, right? You're looking at stuff up here. So one, you've got the depth too deep. Your focus is all the way down here. You're looking at the inside the bone, which you're not going to be able to see. All right, time gain. Gain is going to increase or decrease the overall brightness. Time gain compensation is going to change the gain at one horizontal segment. So each of these sliders is going to be correlated to a segment of the screen, a horizontal segment of the screen. So this is the very top of the screen. So that would be from like here up. This would be the very bottom of the screen from here down, and then the middle. So you get about that much each one.
Is that changing? Is this a software thing after where it's just like brightening the screen, or is that actually changing the focus or like?
It's not changing the focus, it's just brightening the screen.
Okay.
Harmonics help eliminate artifacted deep tissue. I've never used harmonics. Zoom stretches the pixel. It's kind of like blowing up a picture that's not meant to be blown up. It stretches the pixel and makes it more blurry. So I don't use zoom. Beam steering and trapezoidal can help you localize your needle a little bit better. But if you heel toe well, it's better. It's going to be a clearer picture of your needle. So the beam steering, to me, just makes people a little bit lazy, but it certainly can help if you need it. Motion and more. So I think this is important. Doppler effect. I think this is going to become more important as we start looking at soft tissue injuries with ultrasound as they, and we'll talk a little bit about cost coming down at the end, but as the cost kind of comes down with some of these machines, you're going to start to look at things a little bit differently. So if you think about an ambulance, the sound of an ambulance is different when it is coming towards you versus going away from you, and it sounds differently inside the vehicle as well. And that just has to do with how the sound waves are being stretched or compressed. So if you're observer one, it is a lower frequency sound wave because it's going away from you. If you're observer two, it is a higher frequency sound because it's coming towards you and compressing the sound waves as the car moves. And then the traveling in the ambulance sounds even different because it's constant, right? Makes sense? So Doppler, there's power Doppler and there's color Doppler. Power Doppler is sensitive for motion. Color Doppler is going to detect direction of motion. So power Doppler just says something's moving. It doesn't tell you whether it's going towards you or away from you. Color Doppler will tell you if it's coming towards you or going away from you. Doppler shift, transducer should be angled toward the vessel of interest so that flow can be either towards or away. So if you're straight up and down with it, it's going to be kind of red and blue. But if you change it so it's just tilted a little bit one way or the other, it will change the picture. And so what you see here with it straight up and down, now look, that's too much compression. You compress the vein, so you won't see it. That's what it's going to look like, right? When you're straight up and down like that, it's kind of that mixed picture. It's getting it going both directions. But if you tilt it, now you've got red, which is the artery. Is it red because it's an artery? No, it's a red because it's coming towards you, and blue because it's going away. Those are just the colors that they picked, right? It just so happens that the artery is red and the veins are blue. If you tilt it this way, it flips, right? Because now the arterial blood is going away from the transducer and the venous blood is coming back towards the transducer. So the reason for red and blue there. Power versus color, we talked about this. Power is going to overlay Doppler on a grayscale. It's a little bit more sensitive for narrow, small vessels. So you want a powerful power Doppler if you're going to look for neovascularization or if you're going to look for any fluid. It's going to be less reliant on angles of incidence. Color Doppler is going to show the direction of the velocity, transducer dependent. If it's too slow, you might not see it. There are certain ones that only have power Doppler or only have color Doppler and don't have power Doppler. In my opinion, if you're looking at strain patterns and you want to see some of that flow in soft tissue injuries, you need a really good power Doppler. And so that's what power Doppler looks like, right? It's gonna be both straight up and down, you know that it's flowing. There's different kinds of Doppler. I've never used any of this. I don't care about the quantity of blood flow or the resistance. It's just, these are good for cardiovascular things, just something to be aware of. Tissue planes typically image in orthogonal planes. So, we're gonna talk a little bit about how we talk about long versus short, right? So is this in long or short axis?
It's long to the delta.
Right, so it depends on what you're talking about. So you could say this is long, this is in long axis. But if you're looking at the infraspinatus, it's actually in short axis, right? So long and short, it just depends on what you're talking about. Echo texture, I think I've beaten that horse kind of dead at this point, so we'll move on to echo texture. People like to equate things in medicine to food, but the echo texture, you can kind of see the difference between in grayscale, because that's what we're looking at. All right, so the echo texture of a vein, of a tendon versus a nerve. Subcutaneous, if we're talking about that top layer, it's going to be variable thickness, superficial. It's going to be relatively hypoechoic. There's not a ton in there to reflect or to bounce the sound waves back. It can invest into the deeper structures. You get into fascia, small vessels, and nerves. So that's going to be your subcutaneous layer. If we're looking at muscle, muscle tends to look like a starry night. So that's a picture of the Earth from the moon and all the stars. Trying to get an idea, I don't know, it's a bit of a stretch, but those muscles should look like a starry night. You get some of the fascicles lined up, you get some of the fascia coming through, and it's gonna look a little bit different, but short axis on a muscle is gonna look like that. So muscle, the reason that it looks like that is because you have paramecium and epimecium. They tend to be not as well organized. They, as you can kind of see here, right? They're different structures. They're not all the same. And so you can use that starry night appearance to go, oh, look, there's a tear there, or there's fluid there. There's something there that's not supposed to be there. And then you can measure it if you need to. You're going to look at it in short and long axis, right? So you've got the tendon running through muscle above, muscle below. So you have kind of a musculocutaneous or a musculotendinous tear there. Same thing here, looking at it again, you get that kind of hypoechogenetic area that's a little bit different than what the surrounding tissue should look like. Again, imaging both planes short and long. Going back to that same picture, right? Long axis to the myotendinous junction. There, A is this is in the A. If you look at it here, this is what we're looking at there. This is a bursa, so you can kind of see it's a little bit brighter there because bursas shouldn't, but this one has a little bit of fluid in it, so it gives you that target over top of the supraspinatus there, right? You get a little bit of that train track sign from that different media. So then we're going to talk about tendons. Tendons in short axis kind of look like bristles of a broom if you took them and squeezed them all together, right? And that's because there's less variability in what those fiber bundles are. You don't have as many subfascial planes going through. So it looks like a bunched up broom in short axis. This is going to be looking at the subscaps. You kind of get that peas in a pod because you have the different fibrils kind of going through, right? So you've got 1, 2, there's a big one there and another one there. Fibrils, so obviously short axis to the tendon, long axis to the tendon has that more linear look to it. This becomes important when you're trying to differentiate between a tendon and a fiber. A tendon and a nerve. It's that fibrillar pattern there, but nerves can look fairly similar, and we'll see that in a minute. This is a patella tendon coming up, inferior pole of the patella on the left, and you get that kind of swollen, hypoechogenetic to the rest of the tendon area. That's diseased tendon or unhappy tendon. and then you turn on the power and you can see that flow there, the body's trying to heal it. Just another picture, distal aspect. And then kind of a little bit of, this is a ligament, so we're looking at a ligament here, similar to a tendon, more compact. Again, this is a little bit of know your anatomy dummy, right? Like you don't wanna, you know where you are, and if there's a ligament there, go, oh, look, a tendon, right? You know that's a ligament because that's where it's supposed to be. Hypo bone, again, it's gonna be hyperechoic because sound waves really don't pass through bones, and you get an acoustic shadow behind it. And so here you get a couple of calcifications. And so you don't want to say, oh, look, the tendon's torn. You know, it's not torn, it's just that acoustic shadow from the calcification, right? So it's not like this tendon tore here, reconstituted here, and then tore again, and then reconstituted again. It's just being shadowed out by the calcifications. Patella osteophyte creating a little bit of a shadow there, so it's a way to kind of know. So you don't want to say, oh, look, they've got fluid, we better tap that, right? You're not gonna tap that. That's just a shadow.
Biopsy.
Yeah, you're gonna end up with a bone biopsy, exactly. Cartilage is gonna have that interface sign, so we'll look at these as we start getting into scanning. This is the patellar groove here. You can see this is a good picture. It's tough to see the meniscus. This is a good picture of the meniscus here. So you can kind of see the difference in echo textures there, and you know, all right, well, that's not a mass, that's going to be the meniscus because that's where the meniscus lives. So cartilage is going to have that, it's mostly water, so you're going to get that interface sign. So you actually have two train track signs here, right? You've got one here where it's parallel, and you have one down here where it's parallel. You get that cartilage interface sign. Baker's cyst, just looking at the Baker's cyst, you know, again, you have that starry night appearance of the muscle and short axis. You have the hypoechogenetic because it's all fluid, and then it kind of creates a comma around here. And we'll take a look at those as we go through. Nerve is going to have that honeycomb pattern in a transverse view, and so that's important. You can kind of see it here, how it looks like a honeycomb, and how that looks different than a tendon or a ligament in short axis. The supporting tissue, that perineum, epinurium, peri and epinurium, are both hyperechoic and create those hypoechoic in between them. So that creates that honeycomb type pattern that's a little bit closer up. The problem is that the nerve and longitudinal axis, you can see, looks pretty similar to a tendon, right? So you got to be careful, and that's why you want to look at it in two. It's a little blurry, but you want to look at it in two axes. So there, we have covered history, basic physics, ergonomic setup, instrumentation optimization, and appearance in 45 minutes. That's a lot. We'll make sure you guys have access to all of this. Do you have any questions? It's a really thick talk. Hopefully it made it a little bit more interesting. But does anybody have any questions before we get out of here?
Do you mind just going over like probe preference for, so do any of the machines have the hockey stick?
Yeah, so
like that versus linear versus curvilinear, like what do you actually use typically?
So I think for me, the only advantage, because there's such a small difference between the hockey stick and the linear transducer as far as frequency goes, it's the footprint. And so to do a small joint, to do a wrist, to do an ankle, ankles are hard because there's so many bony landmarks that you really have to be good at floating the probe.
Okay.
And by floating the probe, putting a bunch of gel down and then not pushing it all through when you push down. So you really have to kind of float the probe over top if you're using the linear one. With a hockey stick, you can use less gel and you have a smaller footprint, but you still have the frequency to be able to see those superficial structures and you can get to them. So it's much easier to do like a median nerve with a hockey stick because you don't have this covering the whole thing, right? So that really the only difference between a hockey stick and the linear to me is the footprint. The Samsungs have Samsung's have it. I don't think any of the Sonosites do. I know none of the GEs do. And it's one of those things where, can you manage with the linear?
Sure.
You can. Is it worth $7,000 that's the one thing that we need to go over. Is it worth $7,000 to you to switch and get a hockey stick? Unless you're doing a ton of median nerves and small joints, probably not. You can manage with it. So just to kind of get through cost coming down. So everybody's heard of Butterfly, right? I am not a Butterfly rep. They don't pay me. I think Butterfly is incredibly interesting, and as Butterfly continues to get better with their technology, which is very different from traditional ultrasounds, that's going to be what everybody moves to, in my opinion. So what they use are drums and computer chips, right? There's no piezoelectric crystals. Those piezo crystals are super expensive. And there's only so many things that you can do with the software. With computer chips and drums, the drums are being used to create the vibration, the sound waves, and the computer chips are what brings it back. You can look at things in short and long axis at the same time, which is incredible. And the cost is significantly less. So a handheld, middle of the road, traditional ultrasound is going to be somewhere $7,000 to $12,000, $15,000. I think the new Butterfly is like $3,500, right? So you could get a new Butterfly every 5 years, and still come kind of close to one handheld ultrasound, right? So that said, when you're looking at billing and coding, you're going to pay off the Butterfly will pay for itself much faster. And when we go over billing and coding, we'll talk about that. That I can't do billing and coding and this in the same day. I might jump out the window. It's just two really thick, boring topics. But I think that's what you're kind of is the fact that you don't have to use crystals. You can use computer chips and small drums. It's going to get better. They're going to get better at their image optimization. And I do think it's going to kind of change the way we do ultrasound eventually. Other questions about any of this? All right. Go to work. Thanks,
Hey, Rob. Hey, Rob,
Yeah.
can you hear me?
Yep.
Hey, great lecture. I missed the first two sections, but great lecture. The only thing I'd like to add is that the some of the scanners you had mentioned, maybe like 10, 15,000. Most of them today are more like $30,000 to $40,000. So, guys, whenever we ask you to be very careful with the curvilinear and linear scanners, there's a reason, because those are very hard to replace at $30,000 to $40,000 and up. I 100% agree with your comments about the curvilinear. Unless you're going to be doing a lot of hand treatment, you probably are never going to need one, and that's probably kind of be a wasted investment. And the other thing, you guys that have been working with me, you've heard me say, when we do a hip, I want you to press. When we do a knee or another area, I like you to float on the skin, and that's exactly what Rob told you guys. So great lecture.
Thanks. Yeah, and if I wasn't clear, when I was talking about the ultrasounds that were 7 to 15, those are the handheld ultrasounds. When you get into
Gotcha. Okay.
handheld ultrasounds are going to be 7 to 15. When you get into the laptop based ultrasounds, they're going to be anywhere from probably 20-25 all the way up to 55 to probably 50, 45, 50. And then if you get into the cart based ultrasounds, those are going to be anywhere from 55,000 all the way up to 175,000. The cart-based ones are the ones that usually the OBs use, and they do a lot of things, a lot of those things that
3D,
we.
yeah.
Yeah, some of the 3D imaging and a lot of things that we'll never use it for. But when talking about a $5,000 to $15,000 ultrasound, those are the V scans, those are the handheld ones, the Clarius. Some of the ones that are wireless, that the batteries get hot and you don't have a super long charging time. So yeah, if I wasn't clear on that, that's my fault. I appreciate it, Sean. Have a safe trip back from the Greenbrier.
Thanks, and strong work last night. I heard secondhand. Good job.
No, yeah, no problem. Appreciate it. All right, we're gonna take off. Thanks, everybody. I'm gonna stop recording here.